Started, okay. So we'll get started now. So I want to first again thank you all for coming here. Thank you also in the Zoom who is participating in this calibration session by Zoom. Before we get started here, I want to just remind you that next month. We are not going to have a calibration session, so we are going to skip the calibration session on March because, and the reason for that is because that session was going to be on cardiology and test cases in cardiology, and we talked with Margarita Fontana and Carlos, Livia, Marcia, all the team that is working on it. They are changing the test case for cardiology, and it's not going to be done by March. So it's not, we realized that it would not be worth doing a calibration session on a test case that will no longer be used. So we'll have that calibration session as the first one in the next academic year in September. Okay, so March, we are not going to have calibration session. We resume again in April. In May, we are going to have our final calibration sessions for this academic year. Very good. So now I want to thank Suman and Rodrigo and Amy for putting together this session for today. Suman, thank you for agreeing to present this session for us. We look forward to a very nice discussion with you and with the group here. Suman.
Hello, can everybody hear me? I'm Suman Vij. I'm one of the faculty here in CRSE. And I am hosting, along with Dr. Maya and Amy, the anterior teeth cavity preparation calibration session. Oh no. It's not working. Ooh. I pushed the right button.
You know what? First, we need to share your screen. No, we were sharing. You're sharing that problem why it's not working.
Okay, then I can do it from there. Right?
No, let's see. Let me just. No. Just there we go. There we go. It's working. It's here and here.
Okay.
Okay, sorry about that. There were some technical difficulties. The objectives of today is we will present and review the preclinical concepts.
Sorry, Suman. I'm
That's
just
okay.
trying to take this out of here.
That's fine.
There we go. Go back. Yeah, there is something. Okay, go from here. I know what happened. It's because, okay, I think now you're good to go.
Good.
Try your, yeah, don't touch anything else.
I'm not going to touch anything. Okay, so our objectives is to present and review the concepts of anterior design, preparation design from the preclinics, and to also present the clinical and the teaching clinic information for anterior preparations, as well as calibrate for our test cases for the anterior. But before we jump into that, at our previous meeting, there was some discussion about using flowable materials in our restorations. We currently have a flowable, which is a traditional flowable. It's a Tetric EvoFlow. And after discussion with many faculty, we would like to propose the use of bulk fill flowable for a few reasons, but we need to have a consensus on the type of material we want. After reviewing literature, we came up with SDR Flow Plus, but we want input from the CRSE faculty as to which material we would like to have. If anybody has a preference, please share it with any member of the calibration team, Rodrigo, Amy, Andrea, Clarissa, myself, Dr. Noor. And we can review it with the literature, and then we'll come together and present it to the MISC committee for purchase. Please remember or know that even though we present it to the MISC committee, does not mean that we're going to get it. but we're going to hope that we can get it. We would really like to have a bulk fill flowable. Okay, going into class 3 and class 4. The following slides are provided by Andrea Pobasic and Clarissa Fontour from their course in the preclinic teaching class 3 and class 4. For class 3 preparations, the students are taught a step-by-step preparation design. It's systematic. They're taught to do it the exact same way every single time so that they have predictable outcomes for their preparations and for their restorations. What they're taught is isolation from 6 to 11. They are taught to locate the contact by using dental floss, and then they prepare the tooth just below the point of contact using a 330 burr. They wedge the teeth to prevent damage to the adjacent tooth. You'll see here that there's a bevel being placed on the lingual. They are not taught to place a bevel on the lingual. Placing the bevel there is for practice so that they get used to placing a bevel. They also learn to use hand instruments to refine their preparations, mostly because the typodont teeth are very soft. Those final bits of refinement, if used using a burr, it could ruin the preparation. So they are comfortable using hand instruments on typodont teeth as well as natural teeth to refine them. The type of bevel that they're taught is it should be smooth and regular at a 45-degree angle to the cavo surface margin and about 0.5 millimeters to 1 millimeter long. When that's all done, then they check their prep. And this is how they're taught to check their preps when they go up into the teaching or the VIX clinics. You can see here they're taught to make sure that their incisal margin is directly under the contact area, that their axial walls are parallel to 9 degrees to the lingual surface, and that the incisal gingival walls are parallel to each other. And that's what their final class 3 prep should look like.
So Suman, just to clarify this, because there were a couple of slides with a bevel there. Can you just clarify if class 3s in the clinic should be beveled or not?
No.
Okay.
No, the bevel, they're taught to place the bevel simply for practice in the sim lab. They
Okay.
just so that they get good at doing it and doing it the right way.
Okay.
But they're not taught to routinely bevel a class 3 preparation.
Okay. Sounds good. I just want to make sure that we clarify that. Thank you.
So some common mistakes with class 3s. The prep is too incisal. The incisal gingival wall is too long. Your line angles are too long or too round. They're less than 90 degrees to the cavo surface margin, and the line angles may be greater than 90 degrees to the cavo surface margin. Damage to the adjacent tooth and gross irregular walls, roughness, lack of definition. Class 4 preparations. The big question here is when to bevel. And we base placing a bevel on evidence. There is very poor evidence to say not to bevel. The evidence supports beveling. At the school, we teach that there should be a bevel on all class 4s. You will find a small subgroup of D3s and D4s who were taught in a previous sim lab not to bevel. Their current D1s and everybody on the clinic floor is taught to place a bevel on their class 4.
There is a little bit of confusion because the D4s that they are in the clinic now, they are taught to not do a bevel for class 4. Is that right?
I think so.
I think so. So we are implementing that. We are having that type of training in the 519 and 520 now. So the information is out there, but it's current D4s and D3s, they don't have it. We need just to reinforce in the clinic. It's a little bit of confusion because
D1s and D2s learn how to.
yes, now the D1s, D2, they're going to be D3s in the next academic year. They learn exactly what you're going to show now.
So with our rising D3s, they should not look at you and ask you, should I put a bevel? But If a current D3 or a current D4 asks, should they place a bevel, please don't get upset with them. They were not taught to routinely place a bevel in SimLab. If you do encounter a student who does not want to place a bevel, please encourage them and instruct them to place a bevel, because that is what we are teaching. And the evidence supports the placement of a bevel on a class 4. Here are some reasons why a bevel is recommended and taught for a class 4. I'm not going to read the list. Everybody can read, and we all know why. Okay, so in restorative, 720 and 820. That's what we all teach in VIX.
Yeah, so one common mistake that I see with bevels in class 4s is that the students sometimes angle too much the bevel and end up exposing dentin. So I think that that's one thing that, you know, as we talk with the students in the clinic, we should make sure that when they place the bevel, that they maintain that bevel on enamel. Otherwise it really does a disservice if we start exposing dentin there, because bonding to dentin is going to be always weaker than bonding to enamel. I think that's just
Yes, really
something.
important.
Yeah.
To remember is to teach them to make sure that that bevel is at 45 degrees to the cavo surface margin and it stays on enamel. Because as we all know, bonding is stronger, as Dr. Noor said, well, and the literature says bonding is stronger to enamel than it is to dentin.
And one more comment. So if you go to the literature, you can have like a single bevel, short bevel, long bevel, scalloped, straight. We are teaching them to do a short bevel and restrict to enamel. Pretty much this.
Okay, so to repeat, we are teaching them to place a short bevel in an enamel at 45 degrees at the cavo surface margin. And it should be smooth and continuous. So VIX, or the teaching clinics, is 720 and 820, D3s and D4s. They have a variety of test cases. You can see 720, it's just a few, and 820, we up the ante. There's general guidelines for all restorative test cases. Remember, 1 V or 2 Ts will result in a failure of the test case. Any failed test case has to be retaken, and the highest grade that they will get is a 75. We're all familiar with the rubrics for evaluating the test case. RST and V has the different categories: finish walls, external outline, internal outline. Before any of your students take a test case or challenge a test case, they should have reviewed the guidelines for their anterior, or for any test case that they take. If it's at your discretion whether you allow them to continue having met or not met any of these criteria. But take that into consideration when you're grading them. If they haven't met the criteria and you allow them to go, they need to be graded accordingly.
Suman, there's a question from Caroline, again on the bevel on class 4, and the question is it the bevel should go in the facial and lingual surfaces or facial only?
It should be on the facial surface. Again, in preclinic, we have them place a bevel on the lingual strictly for practice. As we know, the more you do, the better you get. And that's an opportunity for them to practice. But when we're treating patients, we're placing the bevel only on the facial surface.
And another comment here, depends on the type of the fracture. If you have a very discontinuous area on the lingual, we're not going to bevel, but at least you're going to have like a round diamond burr to do a small chamfer. I'm not saying you have to do it, depends the aspect of the fracture. So it's not a recommended bevel, but we can make the fracture line is smooth enough to receive your composite, especially we are teaching them, we're going to talk about that in the restorative phase. We are teaching them to do for class 4s a lingual stent and the lingual shell technique. So you're supposed to have a very nice and smooth area on the lingual to have a good adaptation of your composite.
Does that answer the question? Okay, so this is our first
I-
case here.
I have a follow-up question.
Yes,
This is Brent. Brent Kolb on Zoom, sorry to interrupt. So the facial bevel, if the prep does not extend onto the facial, if it's mostly a lingual prep with very, very minimal showing on the facial, would we bevel facial or no bevel at all in that situation?
if it doesn't extend onto the facial, then we are not teaching them to put a bevel on there. If it's a full facial prep, full class 3 facial prep or full class 4, well, class 4 is gonna be facial and lingual, then they are taught to place a bevel on the facial. Okay, so here is our first. Okay, so before we used to do the little flashcards and the poll, from Don Heiss's suggestion, we are going to present what the pre-calibration team evaluated. You'll see where we agreed and where we disagreed because we weren't always in 100% agreement. Calibration team was myself, Dr. Maya, Dr. Karpenko, Dr. Povasic, and Dr. Fantura. Everybody is invited to be part of the pre-calibration meeting for all of this. Please just email any of us or all of us or Dr. Noor to let us know if you want to be included. We'd be happy to have you. It is two pre-calibration sessions. They're about an hour and a half each, and they're done in person at the school. Okay, so this is our first slide. This is our first case that was presented. These are all teeth from the school. When evaluating these, please look at them and think of this as the student is presenting to you as their final preparation that they are ready to restore. They're not asking for an extension or any of those things. They are ready to restore. So the pre-calibration group, we came up with 50% of us at S and 50% of us at T. I'm getting to the reasons why. Oh, finishing walls. No, we had 50-50. Okay, well, we're disputing, but we were split 4S and 1T. The T was due to a critical area at the cervical. You can see that down sort of at the bottom of the cervical portion of the tooth. And the S was given by the rest of the group because of slight roughness at the cervical, and it was easy to fix. So it was a judgment there. For internal outline, we were 100% V because there is caries remaining at a critical area, which is the DEJ, and you can see that there. For external outline, we were 100% at an S. The cavo surface margin is not at 90 degrees. And the rest of the preparation for external outline meets all of the criteria for the S category. Any questions? So when looking at these slides, are there any questions, agreement, disagreement, need for clarification in the Zoom world or in the auditorium?
I don't see anything in the Zoom here. Any question or?
Yes, Amy.
I think we had a lot of discussion. It's worth versus external outline versus internal outline where the caries was left. So I think I had a lot of a discussion whether we take points off on the internal outline due to the caries that was left, or the external, because I feel like the external outline really needed to be extended. However, the internal outline rubric is where we really kind of evaluate the caries. So if it was a V for me in one category because the caries was left, we kind of discussed which category we put that in. So if anybody's confused of how we came up with external and internal outline, we did have to discuss that quite a bit. So I remember that in our calibration session. I just wanted to bring that up, that it was kind of on the fence because you could have probably put that in either of those criteria points.
So the question is from Caroline here. Not sure about the remaining caries. Can you point it out there?
Oh, you should, I think you need to get your mouse and try to go in there. There we go.
Okay. The caries is right over here. You can see the decalcification right here.
Go back one is right.
Yeah.
There we go.
Yeah, here you can see.
There's staining at the DEJ as well as decalcification here. And there was staining. If you look, there's staining up at the top in the DEJ and down here as well. And that's a critical area.
Caroline, does that address your question? Okay. Yeah, she says yes. Thank you. There is a question from Dr. Apse. Please clarify and expand caries criteria. What if the Explorer tip sticks when pressing with pressure?
If the Explorer sticks when applying pressure, it's caries.
In the he doesn't say in the DJ, but I'm assuming that that's
Yeah,
that's
then
what-
it's caries and it needs to be removed.
I agree.
Are we good for this case? Any more questions?
I don't see any other
Okay.
here in the chat. Oh, there's one more. From Dr. Apse again. Do we wipe laterally more or press down? So should you, with Explorer, yeah. Should you press down with Explorer or should you kind of scratch?
Wait, scratch back and forth. You scratch back and forth, and if there is tug back with light pressure, that means that there's caries. And that comes, I believe, from the CDCA evaluator feedback that we got from Dr. Yeaman as how they evaluate. If it's light pressure with tug back, there is caries remaining, and that's how we evaluate these teeth as well.
Yeah, so I think that addresses his question. Yeah. And he says, thank you.
You're welcome. Okay, so moving on to the second case. This had a lot of discussion as well. The pre-calibration sessions are very animated. There's not always consensus. All right, so for finish and walls, 60% of the group felt that the problem was moderate and the problems were fixable. It gave it a T. No, actually, there were two people. 40% of the group gave a V, and we felt, I'm putting myself in that boat, that the issues were severe and that correction would compromise the final restoration. Are there any questions about the finish and the walls? Moving on to the external outline of this canine. Within the pre-calibration group, 40% of us felt that it was a T in the external outline, that the issues were moderate yet fixable. 60% of us felt that the issues of the external outline were severe as well, and that there was a damage to the adjacent tooth, which you can see on the amalgam there. We did not cover internal outline form with this case. Are there any questions regarding the external outline? So now we have our third case. So for this case, we are evaluating and this was my question in the pre-calibration. We are evaluating the portion next to the orange wedge. That is the preparation. So for 100% of us, for finish and walls, we felt that this had severe unsupported enamel, which would put it in the V category. For external outline, 100% of us felt that this preparation was overextended incisally, which gave it a V. There is caries as well remaining in this preparation, but that was not evaluated with the internal outline form. Moving on to the fourth case, but before, let me go back to the third case. Amy, you have a question?
Yeah, I just wanted to point out that I didn't see the unsupported enamel at first, and everybody had to point that out to me during the calibration session. So it's kind of hard to see on the photo, but now once I saw it, I understood it.
It's right here.
Yeah. Yeah,
Yeah, it's right
there it
here.
is. It's right next
almost
to the
like
wedge.
like a J.
Yeah. And
almost like
I
a
just
row.
wanted to make sure because I didn't see that on the screen. So I was really confused why you all thought it was really unsupported, but it was my angle. So I just wanted to make sure everybody saw that. Once you pointed it out, it was really blatant to me, but that had to be pointed out.
The question in the chat was also about where is the unsupported enamel? I think that Amy just addressed it.
Yeah. And that it's right here, right next to the wedge. It's kind of like one of those puzzles. What do you see in the picture? Can anybody see the fish? Well, this is where it's at right here.
From Dr. Apsey again, the photograph doesn't always reflect the various factors. Yeah, it's a very good point. Yeah.
Absolutely. Photographs do not reflect all of the different factors. If you're in clinic and you see a great case, you can do video and you can do photographs with the intraoral cameras, and we would welcome those images to present inside of the calibration session. If you're able to make a video that will allow you to take it from multiple angles where a camera may not, that would be great. So anybody out there, we would welcome your photos and your contribution. Any other ones? Uh-oh. Okay, I just lost my notes for a second here. There we go. Okay, so this is our fourth case. That's okay. You can stay. All right, so this is our fourth case here. For finish and walls, 100% of us said that there was unsupported enamel at the incisal, and it was severely rough, and it placed this preparation, in the V category. And our unsupported enamel is right, this guy right here. Any questions? Oh, here's the outline of the prep right here. It's got like this little wavy right here, and it comes down and it comes up here, and then right down like this. And this is the portion of the unsupported enamel right here. It's like a little peninsula hanging down there.
So, but how would you fix that?
Well, when you fix it, it's a pretty big problem, isn't it? Then becomes a class 4. And that's what pushed it into the V category, like, because this is the final prep that they're showing us. This, if this student was preparing this and stopped and said, I need an extension and I need this and I need that, then that would change the score because they've asked the appropriate questions at the appropriate time. When we look at this, we just think they went gangbusters
Mhm.
And presented this to us.
But do we all agree that that it is best for the patient to transform this class 3 in class 4?
No.
So can you explain why?
So Jackie was asking to instead to keep like this and restore some unsupported enamel, to move and cut the point angle and transform the class 4. We are cutting too much of the tooth structure. And I think the technique to be done in clinic is you need to try to support that corner as best as you can. And then you're going to finish your restoration and finish your contact and try to achieve the right contour of this. However, how predictable this is going to be in the future, the area is not an area with a lot of stress. So most likely you're going to be safe. And one point that is really important is the amount of tooth structure that we still have. More than 1 millimeter, we are supposed to be okay having like a nice composite to base this up. This is just like what I think, but some people are going to cut that as a class 4.
It's not just to say because of the angle that we're seeing. It's difficult to say because of the angle that we're seeing. We don't know the amount of unsupported enamel inside that area. So it depends.
I think we have people in the chat.
Yeah, so there is a question here. Why would you want to extend more and create a class 4? That's exactly the same question that I had. And then the comment is possibly just parallel the Invisalign in gingival walls, not the Invisalign, the incisal and the gingival. Possibly just parallel the incisal and the gingival walls. Would that be the best approach here?
So it's a little bit hard to make that determination because we're not sitting inside the prep looking up. We don't know how much unsupported enamel is there. If we have 1 millimeter or greater, then we're within the limits there. If it's less than that, you can support that with composite, but your long-term prognosis on your restoration is not that great. Because there is going to be some type of fracture of that unsupported enamel at some point. This is, again, a low stress area. So when that's going to happen, we don't know, but it's likely to happen.
Okay, so we have a comment here from Nancy. We have to remember we have not seen the pre-treatment caries. And if this was overextended or if the decay would have caused this extension. Yeah, very good point too.
Yes.
Yeah.
And again, we're assuming that this was given to us as their final preparation without any request for an extension or any guidance through the test case.
So is it fair to say then that, most of us here think that we should not transform this class 3 into a
Yes.
class 4? I see some nodding here.
Yes.
Okay, that's good.
I think everybody in the room, I don't know about on Zoom, agrees that if possible, try to keep this as a class 3, inform the patient of the prognosis and a possibility of having to do something different in the future. Okay, so the next part of this tooth of this preparation is external outline. 100% of the group felt that this was a V. There was a nice damage here to the adjacent tooth, better visible here, as well as this prep is overextended. Because again, that's based on showing it to us without, this is their final prep without any request for an extension. If that's where the caries took it, then the grade would be different on it.
So a comment from Caroline here. She says also that she agrees that we should not extend into a class 4 and keep it conservative. And my question to you here, is it, the dent in the adjacent tooth, is the external outline the right place to indicate that? Rodrigo is saying yes.
The criteria shows if you look at the V external outline, severe under or overextend, lines or curves, severe irregular, severe damage to the adjacent tooth. Yep.
And the damage on this tooth would require some type of restorative material placed. Because if you polish that, you're going to make.
To restore.
Yes.
If you can polish the damage to adjacent, it's going to be a T. If you have to restore, it's going to be a V.
And I think we agreed in the pre-calibration that if we polished this, the final restoration on the lateral would be, the contour would be really wonky. Any more questions about this one? Okay, well, the fifth and final case, because I go too fast.
We're gonna go probably back to the posterior, like the posterior bulk field discussion, see if we can get an agreement today what to do. Yeah, Suman is going a little fast. So what we're gonna do, probably gonna finish the case criteria and then go back to our discussion, since we have time, to try to make a decision about not the brand, if we need or no to get, instead of to have a conventional low viscosity composite, like we have now in the clinic, there is a tetric EvoFlow, to move towards a bulk fill low viscosity as well. So we're gonna revisit that topic.
Okay, so after we finish our fifth case here, this is our finish in our walls. %100 of us said that this was a T and that the prep was very rough for the finish in the walls. Any questions? For external outline, did we do external outline? Oh, I don't have the score on this one. Okay, so for external outline, oh, there we go. It's 100% of us said it was a V because it was overextended and there was damage to the adjacent tooth. You can see the damage a little bit better in this photograph here. Any questions on this one?
There's no question here in the chat. So this one here, probably you could address the adjacent tooth just by smoothing that out, right? Without a restoration. Is that what you guys decided, or you think that you need a restoration?
This one, I think we agree with a V. I don't think we can buff this. If you look the contour of the restoration that has been damaged and where is the enamel area on the incisal of the preparation, if you try to bring this down, you're gonna end up with an over contour on your distal restoration of number 8. Okay. It looks.
Yeah. No, I agree. So there is a question here from Caroline. Why overextended? It looks to me like there is still caries in the cervical and actually underextended for the external outline. I would be asking for an extension cervically to deal with the decay and caries at the DEJ.
Okay, so this is presented to us without the ask. This is the final I want to restore presented to us. So we're not addressing the remaining caries because we didn't do internal outline form. But yes, if we were grading internal outline form, this would be a V because there's caries remaining. It's overextended because it's overextended incisally and cervically without asking for permission. If they'd asked for permission, that again would change the grade.
Okay, thank you.
Okay, so that's all we have for cases. Are there any questions regarding class 3 or class 4 preparation, design, or evaluation?
Hi, this is Brent Kolb on the Zoom. I have a question about calibration. I don't know if this is the right time to bring it up or not.
Sure.
I appreciate all the efforts. This is helping a lot with kind of clarifying how the test cases go. But I'm a little concerned that it's showing how uncalibrated we are. There are certainly instances where even the calibration team has, 60% scored it one way, 40% scored it another way. And I also realize that the human element here means we'll never be 100% calibrated because there's a variety of opinions, and some wear loops and some don't wear loops, and some have LED lights and some don't. And I guess, is there a system in place to track how calibrated we are or are not? Or is it just kind of the ongoing efforts and our perception of how well we're doing? I guess another way to say it is the school tracking the scores that faculty give on test cases to see who is calibrated and who's not in terms of grading? If you have one faculty that always gives R's and one that always gives B's, maybe that stands out and the school can track that and then certainly kind of address that with those faculty. I don't know if that question makes sense or not, but how do we know if we're calibrated or not is, I guess, the overlying question.
Yes, this is $1 million question. Nobody gonna have the answer because calibration is a process. And what we are trying to do, we are trying to just get to the point with those sessions. And then the idea is bring the same case later on and see if we can start to get like a better agreement. And I'm gonna say a better agreement when we see our pre-calibration team going to 60 to 40%. This is 6% agreement in dentistry is something really good. You're never going to get close to 75, 80%. So the idea is bring the same case, revisit those cases, and see if you have a more clear vision. The other idea that you gave to us, looking who are the hard graders, who are the one who only gives R's all the time, we don't have that in place. We can probably try to track this down and approach those faculty more often and say, okay, let's go back, and because we're not going to have the photos from the test case, but we know who's a soft and who's a hard grader. Yes, we know. But the idea to calibrate those people is very challenging, because calibration means we need to provide some information. This is exactly what you're doing. This is a phase 1 of calibration session now. And then we need to assess the results later on. So we are not even assessed. We are just trying to create a vision, what are you looking for, and bring back the same series of cases in the next series of calibration and see if you get better until the point to say, okay, we are pretty much now, when you look something like that case that we are seeing the screen right now and say, okay, that is supposed to be a V is 100% agreement. So we're trying to find this out. How can we bring the people together? And then this is, I'm not going to say that we have to do like this, but that is supposed to be much more productive if you have an in-service day, the entire day, the whole faculty together in person. That is going to be something that I don't know if it's going to be possible, but you're going to generate much more discussion. We can do something in the morning and then reassess those results in the afternoon. Yeah, those are like a very challenging question. Is in a variety of people that we have in the department. As you said, somebody use a 10x magnification with a LED. Some other one they use a 2x magnification. Some of them no magnification. So how are you going to grade? This is like a battle, but we need to try our best to be able to be fair and teach what the department thinks as a philosophy for the students. Yes, good question.
Any other comment here about this? Because this is really important. Yeah, we definitely want to come back to this in the future at some point and reassess us to see if we can come a little bit closer. But any other point about this, the issue of calibration?
I think it's also important to remember when you're grading test cases, it's the discussion part of it because we all see things differently. So when there's two of us evaluating, that's why you have two and you discuss what we saw, why we saw it, why we are grading in that category. And that's, you know, as Amy said, we had some pretty heated discussions about why we put a certain grade on the preparation design. And then you come to a consensus on the grade. So a large part of this is too, is it's good to see the discrepancy within a pre-calibration group because it reflects the importance of discussion to teach our students.
Yeah, Suman, so there is quite a few comments now here and questions too. The first one is from Dr. Harris. Can you please go over the indication of when the student need to remove all existing composite or restorative material as opposed to just resurface it? This is not here, but I think it's a good point that you.
I can comment on this. So this is a very good question. Say to be conservative, we're going to try to remove as minimal that you can to replace. But the question comes to the point is, we don't know in who placed the restoration, how was the bonding. If it's your patient in your practice, I think you can, you see a margin defect or something that just came out for one of the cable surface margins, say, I can remove a little bit, get my disc, remove some prismatic enamel, and then I can bond on top of it. And to bond on top of it, it's like you're doing a repair in a composite restoration. So we do have few steps to go that I don't see that in clinic very often. Then there is a big discussion. What should I do extra? You're going to clean, you're going to use a silane or no silane because you're bonding to a composite that has been in the mouth for a long time. So there is some contamination. There is some area that you don't have the oxygen layer anymore. So to bond to that, we need to create a surface to be able to receive our bonding and then some composite on top of it. My question is, if the student told me I did that restoration like two weeks ago under isolation, and now I have that area that just came out, I'm not going to say remove everything and let's do it again. But if you don't have records for this, the idea is you cannot rely on somebody else's procedure to just bond on top of it because we never know what's going on with that restoration. Any comment?
So your take is if it is a feeling that you supervise, that you know what's underneath, then you can simply do the repair. If not, take it all completely and redo it. Is that your take?
Yes.
Any other thoughts on this, Amy?
Now you can see why we get heated in our pre-calibration sessions. But what about if you're compromising, let's say it's a really, really, really large composite and you're compromising the structure of the tooth, you're compromising the pulp of the tooth, you know, and you have very, very clean margins. Where do you make that clinical decision to say, okay, if I take all of this out, I'm really risking, you know, fracturing the cusp while I do it. I'm risking a pulp exposure because it's very deep. When do you draw the line? I think that could be on a case by case basis.
It's a case by case basis, but again, how are you going to judge how was done that preparation or the restoration, which circumstance led you to see a fail in that restoration that you're going to say, okay, I'm going to just repair. If my stuff it can repair, I don't feel doing I'm going to say a good service for my patient if I'm repairing something that I have no clue who plays in which circumstances. And then this is a risk. As you said, the risk is trying to remove that restoration, being as conservative as you can, get you a big magnification on, very slow, little by little, try to trace it down. And then we do have some clinical strategies to do that. Even if you have composite, we have some filters to put on top of the LED light and try to see what is still having composite and just go and remove even as low. So this is most likely a clinical approach to do it. I don't feel comfortable redoing or repairing stuff that I have no idea what people did for the bonding or the restorative phase that I was not present. So is a risk. But bond on top of something that you have no clue what is underneath that because you can see it is another risk too. Pick the risk.
Any other comments here before we go to the next question in the chat?
She's always mad.
Okay, so the next one is from the next is a comment from Dr. Abse, and that is we need to calibrate to standards required for the board exams. That should be the focus. Yeah, that's I totally agree with that, and that's exactly what we are trying to do here and using the criteria for the boards as a reference. Then there is a question from Dr. Hartzell. To repeat the external outline form for the final case by criteria at the beginning, should the prep have been seen at the outline just below the contact point to have not been considered overextended? I think that this was regarding the last case that we had there.
Are you dizzy yet?
Should the prep have been seen at the outline just below the contact point to have not been considered overextended?
Yes, this is the last one.
So this is the last one, yeah.
Should the prep be seen?
Dr. Hartzell, can you unmute yourself and explain a little bit better to us what the question is? We're all having a little bit of a hard time. Yeah, we can hear you now.
I just meant, that prep sort of extended above the contact area. And if they would have made their initial outline form just below the contact area, even if they had to extend it, I mean, there were other things wrong with the finish of the walls, but even just when we were discussing, was it overextended or not? I think it did, the criteria that they showed on the very first slides with the measurements, that preparation didn't start just below the contact point. So I thought that had been a simple answer to the discussion of was it overextended or not.
Yes, so to Dr. Hartzell clarified why we think that we said that this was overextended, and it does reference what they're taught in preclinic, which is really important. That this preparation did not start, the incisal wall does not start just below the point of contact. It starts above the point of contact. And if we're referring to this as the final preparation without asking for an extension, based on what the students are taught in preclinic and what we teach them in clinic as their starting point, this prep is overextended. Thanks, Nancy, for clarifying that.
Very good. So there is a point made. So there's a point here made by Dr. Romzik, and that is, which I think is a very, very good point. When I work with my colleagues on Fridays for a test case, we always follow CDCA guidelines and ask the student to establish ideal outline form first and show it to one of us, and then use that as a point at which they decide if they need to make extensions. We make it clear to them that they need to stop at ideal, but they have to know what ideal is to start with. Yeah. So I think that I totally agree with that approach. Any other thoughts about this? Comment from Caroline.
This is pretty much what I think every faculty did. Yes, Caroline, I think this is pretty much what most of the faculty that I teach with in the floor, we do that too. So we go by the criteria and then they start to do the access and then carries remove, and then they're going to stop and show us. So this is, I think, it's the way that we are supposed to teach. Get a guideline and then explain to the student when they need to call you back for an extension or for a modification. Yep.
And I think it's important to remember that that's part of the test case. They are taught what is ideal in preclinic.
Yeah.
And when we tell them to prep to ideal and they don't know how to do that, then their score reflects that they don't know how to prep to ideal.
This was the last comment here that I have now.
Okay.
So we're going to ask Suman just to go back to our slides about posterior composite and see if the group wants to move in which direction. We don't. So now what we teach in SimLab is they are learning to do open sandwich technique. So we have resin modified glass ionomer. So for those deep cervical areas in a class 2, most of them, they do a base with glass ionomer and then they restore with composite. However, we got a discussion say we do have some low viscosity composite in the clinic. At that time, if you look at the dispensary is we have the Patrick Evo Flowable. So this is a conventional composite, and we don't teach the students in the D1s to use Flowable. They don't have Flowable in the SimLab. Since we are trying to align all the techniques, materials, instruments from the SimLab in the clinic, this is one point now that came up as a good point of discussion, and maybe we can try to get close to a consensus today to make a recommendation for the MIS committee. We're going to keep the Flowable that we have in the clinic, and we're going to teach the technique in the lab, or you're going to get a low viscosity composite and switch our conventional Flowable for a bulk fill. So this is something that we are open for comments, suggestions, and see your thoughts.
So I think that one first comment here, and perhaps a point of start here, is that is to make a decision in regards to the standard flowable composite. Do we have any indication today for a standard flowable composite. And so I think that if we start there, we start taking out pieces of this discussion here, because my understanding of standard flowable composites, I'm not talking about the flowable bulk fill. I'm talking about the standard flowable composites, the old ones, the ones that we have in the clinic, because they have so much organic matrix, they shrink so much that you really absolutely have to have excellent bonding to avoid the opening of an interfacial gap. Now, we don't get excellent bonding typically in the cervical of a class 2. So I would start there and say, do we really, should we still have a flowable composite? Is there any place where you would use a flowable composite, a standard flowable composite today? And if we say no, then we can have a conversation about changing to a flowable bulk fill, which shrinks much less. So you don't have to have such strong bonding, and perhaps consider this material as an indication for deep class shoes. Do you get what we're?
So not only class, because there is some people, and then we are talking about now class 2s, but if you go to the literature, there is some indication for using low viscosity composites to do some class 5 as well. But the C factor of those class 5, they are so huge. And I understand the technique, but I think if you wanna, we don't teach that, but if you wanna go to that direction, and that's why we have like different clinical backgrounds here to bring to the table to discuss. What do you guys think as an indication for a low viscosity conventional composite? Yes or no, keep, or we're going to move for something that we have less shrinkage stress, we have a superior degree of conversion, and we have much more inorganic fillers that some of them now, they are 75% kind of a conventional composite with a new chemistry bulk fill that we have in the market. So this is something that we can bring, finish, try to get some food for thought today and try to make a decision. We have some comments.
So there's a couple of comments here from Dr. Apse. Bulk fill
May
for
I
most
interrupt?
depths. Yeah, Mark, you can go ahead, and then I read later the
Thanks.
comment from
I
Dr.
would
Apse.
prefer to use the share on the Zoom, but I'm struggling to get my share to work. Maybe at a later time, somebody will tell me. So what I'm about to say, I'm sure will lead to lots of comments that really we shouldn't have now, but you're asking for ideas. I am a big advocate of cautery. I had a cautery unit always set and ready to go at my side. I had 8 or 10 different nose caps and tips, so sterilization was not really an issue. And I could, in deep cervical areas, the tissue is the issue. I could get rid of the tissue. And I think that that's a formula for good success in an easy way. So we don't need to go into that. I wish I had screen share.
Does anyone want to comment on this?
So I think the use of gingivectomy and tissue recontouring is a great tool in the clinics to help expose areas so that we have access to them. But in terms of restorative material, when you're talking about bonding to different substrates, whether or not the tissue is exposed, I mean, we're talking about bonding to the tooth. And it's really important to have it exposed and have access and fluid control, but those don't contribute. That's not the bonding material, right? So when we're talking about bonding to cementum or dentin or different substrates for a class 2 or a class 5, we want the best material possible for our students and our patients' success. Like Rodrigo was saying, we teach the open sandwich technique, which is shown to be the most successful for deep class 2s. but we would like everybody's thoughts on moving from a conventional flowable composite, which has high shrinkage, to a bulk fill flowable composite, which has much less shrinkage stress, has high conversion, does allow for much better long-term success of restorations. These materials, they have up to 4 millimeters of cure. They do need to be capped though, because they're kind of gray. Some materials will tell you that you don't have to. The vast majority do need to be capped with at least 1 to 2 millimeters of standard composite material. So we'd welcome anybody's suggestions or thoughts on moving from.
So there's a couple of suggestions here, Suman. Bulk fill for most depths makes it stronger, durable composite. Monolithic materials are better. So that's a comment from Dr. Abse. From Dr. Kolb, 2 possible indications for standard flowable PRRs. Oops. PRRs in repair of temporary crowns. Bulk fill flowable needs top layer, so cannot be used for PRR. Yeah.
My understanding is that based on the material, the newer bulk fills that have low viscosity can be used in PRRs. They're going to be a little gray, but you can use them.
And going back, we are not doing PRRs as a standard of care. We are doing sealants instead of PRRs using composite. So I think there was some discussion that we did with the cardiology group the session that was led by Margarita last October, I think. So, and the philosophy is if you need to seal, you're going to use a sealant to do it. And another thing is, I think, yes, this is a good material to do some repairs and some temporary crowns, yes. But you still, if you want to like a flowable bulk fill, you're going to do the same type of service. The only thing here is I'm not advocating that we have to have a bulk fill. And if you look, most of the evidence you're going to show is very weak about those materials. They are like 10 to 12 years in the market. There is not a lot of randomized clinical trials. They are good materials to be used. I think we can trust in some of them. But if people said there is no need to have it, I think we're pretty like solid doing the open sandwich technique with resin modified glass ionomer. And then we can open that for another type of discussion. Should we have a pure GIC instead of a resin modified glass ionomer as a secondary option in the clinic? This is another thing too. But again, I want to see the group. What do you guys think? Should we go switch the traditional flowable for flowable bulk fill, or keep just the resin modified glass ionomer and open that for another category of material in the clinic?
Any thoughts from any one of you here?
I can put in a few comments. This is Dr. Kolb on the Zoom.
Yep.
I think the new chemistry bulk fill, I think is how you have it listed there, makes a lot of sense for a lot of reasons as a posterior composite. It does not require the top layer. So it kind of minimizes the chances for contamination in terms of layering composites in the posterior. Probably decreases the chances of sensitivity and hopefully increases the time it takes a student to do a restoration when they're not having to layer multiple composites. That time, I think, is super important because they're slow and they're learning. But the more time it takes, it's the more opportunities to contaminate the bond at various levels. To me, that makes the most sense over a flowable bulk fill, where you would, again, do a bulk fill in the flowable material, but then have to pause, switch materials to put a top layer of 1 to 2 millimeters of a standard composite. That just doesn't gain us a lot if using it for like a standard posterior composite. in my opinion.
So, you are advocating then, or you are saying that instead of using flowable bulk fill, we should do the entire interproximal box with regular viscosity bulk fill. Is that correct?
That's correct.
So any comments about that? Here, Rodrigo, Suman, and
Yeah, this is just like another type of technique that we have. Instead to have that, so we're going to pretty much lose the ability to have low viscosity composite in the clinic. But again, we are totally open for discussion. And if this is the way that we want to teach, we need to adapt our sim lab course to teach that technique as well.
And if we move to the new chemistry bulk fill, then we'll have to have two different types of composite, right?
Yes.
And there would be the posterior composite and then an anterior composite.
so this is from Dr. Hartzell. I'm not clear exactly what we are teaching as the indication for flowable resin of any form, and why is it in our material manual? Can you address that?
Yeah, it's in the material because, as you said, there is some material now in the clinic that we don't teach in the same lab. But as per suggestion, I don't know, there was prior I joined to the group, I came there and I asked Patrick, who has all the material list, and I saw a lot of material there say, we don't teach that, we don't teach that. Oh, but a faculty like that. How did you get to go to the clinic? We don't know. I don't have the answer. Maybe Dr. Hayes has the answer. He's shaking his head. He said he doesn't have the answer as well. However, this is exactly what you're trying to do. We are trying to revisit those materials and say, we can eliminate this, or we can add this, or you can switch that. This is exactly what I'm trying to do. And this is as part of the plan of the discipline to try to establish a very concise materials, instruments, and techniques from day one in the dental school to the graduation day.
We have to consider that other people use the clinic as well. Maybe the materials that are there are not exactly for restorative purpose, or somebody else is using.
Any other comments? Let me see here if there is one from Dr. Absey. Agree, new chemistry bulk fill should be recommended. A comment from Dr. Romsik. Tetric flow can be used to repair margins on provisionals and beef up weak proximal contacts on the provisionals. Yeah, so that the comment here is that perhaps that could be also used for the pros from the pros faculty. Well, this issue of class choose is a complicated one, right? We are seeing that each one of us here probably have a different strategy to go about it. I for many years, I used to do glass ionomer, resin modified glass ionomer, and then put on top of it the composite resin. And that works well, even though the marginal seal is not perfect, but because of the fluoride release from the glass ionomer, you rarely see secondary caries in these class twos with glass ionomer and composite resin on top of it. I would use resin modified. I would not use the conventional glass ionomer just because of the time. I mean, the conventional glass ionomer, you have to wait quite a bit to be able to bond on top of it. And while the resin modified, you can get it done right away. But that's one possibility. I think that the other possibility here would be to use one of these bulk fill strategies that we have here for doing these restorations, and certainly these are newer materials that shrink much less than the conventional composites, or much less than the conventional flowable composite. I think what we will have to do here is perhaps find a way to get input from the faculty, both written and verbal input, and then a smaller group will have to sit together and make a decision. We are not going to find a consensus here, I don't think. But a small group then would have to make a decision and communicate that very clearly to all faculty that that's what we should do from now on. So I propose perhaps that we collect input. We perhaps prepare an email, Rodrigo, with the 3 or 4 different most common approaches for class 2s. We collect input, and then we get a small group, and I would love to have some part-time faculty input in that small group to make a decision and then communicate with everybody, because otherwise we may stay here for a long time and not find a full consensus among ourselves. Would that be a reasonable approach?
That's good. Yeah, so it's fine. So for me, I can send this out. I'm going to leave tomorrow for a meeting in Chicago. So when I come back during the spring break, I'm going to send an email to everybody, and then we are more than happy to get all the inputs and try to get an ad hoc just to make those kind of preliminary decision. But please be available to come and discuss with us. Don't leave on us that decision. As Jack said, we need to have input for everybody, and then we want to teach as what we have as a best evidence out there and make that available for our students. This is exactly what we're trying to do. Any other comments?
Okay, so let me just go through quickly here. There are a few other comments here. Agree, new chemistry bulk fill is a very good option. This is from Dr. Harris. Dr. Apsey, will there be an email invite for the small group? Yes, Dr. Apsey, we'll send an email invite, and whoever is willing to help us out will certainly be welcome to this group. There is a comment here from Caroline Romzik about the use of cameras in the clinic. Before we go there, is there any other comment or question at this point about anything that was covered today from the? What are some of the brand names?
We have a lot. So we have so there is a question here, say, what is the brand names for those new bulk fill composites? We do have a lot of them. So we can bring a list with the most popular ones, the one that people are using the most, they are testing the most. And then we can put a list. And I got some information for people like the US Navy, they love one type of bulk easy, and say why. I don't know why they like it, but they like. So we're going to bring those down, and then we can open for those type of discussion, but there is a lot of them. 3M has one universal one. Even the new SDR is a new chemistry as well, but for this, it's totally flowable. So we have 2 categories, low viscosity and regular viscosity. So we can list some of the top brands, and we can put that in the email. Yeah, Jackie say, I probably going to do like 4 to be fair with the manufacturers. They're going to do pretty much the most popular ones, the most one that we have some scientific evidence about those materials. Yes.
Very good. So, Caroline, would you mind to unmute yourself and if you can, if not, I can read. It's a kind of a long comment that you have here, Ben. Can you unmute yourself, Caroline?
Yes, can you hear me?
Yeah, we can. Thank you.
Thanks. I just want to give a shout out to everybody, all the adjuncts who teach on the clinic floor, that we've got the new mouthwatch intraoral cameras, and we use them all the time on Fridays now, ever since they hit the clinic floor. But the comments that we have from the students is that we're the only ones that ask them to plug them in and use them. And I don't know if other faculty are just not comfortable using them, or they just are unfamiliar with them. But the mouthwatch cameras that the school purchased for use in the clinics are absolutely amazing. The resolution on them is crazy. And we've had students using them for new patient exams. We've had them using them for prophies and periodic maintenance, patient education, and in particularly in restorative for their preps. And when they take a picture of these things and put it on the screen and it's magnified, I don't know how many times, we're actually able to use the pictures on the screen for the teaching points, rather than trying to have them look over our shoulders and try to see the areas that we're describing and pointing to in the preps. And so the kids are geeked when they actually see how easy they are to use, and the resolution that they can get with them. The energy that we see in our clinic and the teaching moments that we have on Fridays is amazing. And I want to propose that we go one step further, and this would be for Rodrigo and Amy and Suman, and propose that we start using them for test cases. Take a pre-op photo of what this looks like, and then have the student take the photos of their final prep and their final restoration. And we can use them for discussing when we're talking about the grading. The faculty can always go back and reference them. And then there's also documentation of what the student actually did. And if there's any concern or any complaint or any dispute that they want to register, the picture's right there. So I just want to give a shout out. The school went to a lot of effort to get these things into the clinic, and they really did a fantastic job selecting this thing. It's very user-friendly, very plug and play. And I hope that our 720 and 820 directors consider using them for test cases moving forward.
Yes, Caroline, thank you. And I agree with you. So I think most of the faculty are not using that tool as part of the teaching in the clinic. And I don't know why, because maybe people say it's another step. This is a plug and play, put it in, get your image. Pretty easy. The students are gonna like, even to educate some patients. And I agree with you. And part of our plan for the next academic year, we couldn't change this year, but as part of the test case, they're gonna have all the steps that need to be recorded. So we're gonna create a huge data bank with those preparations, with some good ones, bad ones. This is our idea, yes, in the list. And I think you're gonna be in, like, as part of the test case, as a requirement, like they have to have an X-ray, all the steps. They're gonna have the caries removal, prep, and final restoration for image that are gonna be saved as part of the test case, yes.
And I just want to add one more thing. The very first day we used them, and I can't even remember who the student was, but it was a new patient exam. The patient was a lovely woman, and the student came up with her proposed treatment plan, which amounted to 2 resin restorations, and it was grossly under treatment planned. She was trying to rebuild 2 teeth with composite that really needed to have crowns. Anyway, we took pictures on it, and the patient came around and sat in one of the stools and actually looked at the photos. And when I was talking with the student and the patient about how compromised the teeth were, the patient was just blown away. And the student said to me, well, she doesn't have insurance. And I looked at the student, I said, okay, but let's treatment plan ideal here, and then talk with her about what's best for her. And if money's a factor, then okay, we take that into consideration. Well, she had never talked to the patient about money. She just made the assumption that she had no insurance. And so she wasn't either willing to or able to afford it. At the end of the appointment, the patient accepted treatment for 4 cores and 4 crowns. And I think that it was not only a teaching tool for the student, but the patient education was valuable. And I don't want to say that we sold anything to this patient because these were very needed restorations. So it's not selling, it's about patient education. And so it was not only benefiting the student, but also the patient. And now the student's going to have 4 crown opportunities instead of 2 huge composite resin opportunities.
Yeah, that's such a great story that you had to share. Thank you for sharing with us, Caroline. I can see how this was a great experience for the patient, for the student, and for us as faculty. So there is some comments here about the cameras too, from Dr. Schaff, a fantastic idea. From Dr. Epsey, yes, those cameras are excellent for case presentation and discussion with the students. So I think we all here are with Caroline in encouraging all of us here to give it a try, to use these cameras and work with the patients and the students on it. And I also think that it's a great idea to move towards using it in test cases, not only in terms of a learning opportunity for the student, but also in terms of documentation, which I think is very, very important. So very, very good. I don't see any other comments here in the chat. Are there any other comments here from you in the room? From Suman, you've been quiet now. You got.
You can read that. Your Bisga sent something. Team Bisga sent it to me a text message. Go to the Zoom chat, Bisga. Say great stuff. Bulk is needed. Let's try to pen on that. Thanks, Bisga.
Very good.
I think it's good. I'm here.
Terrific, terrific. Suman, any final comments from you or any wrap up?
I have no questions or comments at all. But for everybody out there in Zoom or here in the room, any questions, comments about flowable composite, about preparations, about usage of the camera, any suggestions that you have to help improve the test cases or teaching in the clinics, please feel free to email any and all of us. We're all here to work together as a team for our students.
Terrific. Thank you, Suman, for putting together this presentation, for presenting, for all of you that work on calibrating these answers, for all of you who participated here and in Zoom. And I just want to, again, in closing, saying that in March, we are not going to have a calibration session. That calibration session from March will be done in September. And the reason for that is because it was supposed to be on the cardiology test case. The cardiology team is changing that test case, and it's not going to be done by March. So we would rather just spend that time when we have the new test case, and then we can discuss it in more detail in September. So next month, March, we are not going to have a calibration session. We come back in April for calibration on digital, use of digital in the pre-docs, okay?
So yeah, we don't have on March a calibration. We're gonna have, Jack, we're gonna send an announcement. We have a faculty meeting on